Hello and welcome to our podcast. I'm Dani, and today Break.com talks with Johan Claassen, Director and Coordinator of Aid to Africa, an humanitarian division of Doctors for Life International. When you hear this podcast, remember to press subscribe on YouTube or in your podcast app. Hi, Johan, and welcome.
Thank you very much. Thank you for this opportunity.
Now, I'm really glad to talk to you today. Johan, could you tell us about how Doctors for Life came into existence? Let's learn more about this genesis.
So Doctors for Life came into being in 1991 when a group of doctors in South Africa came together and basically to establish three principles in this organization. And that is a basic Christian, Judeo-Christian ethic, sound science in the medical profession, and the sanctity of life from conception or fertilization until natural death. So this group of doctors then formed Doctors for Life, and we are basically a voice on behalf of our members on different topics uh, that involve medical doctors in their profession, things that they have to deal with, ethical issues they have to deal with on a day-to-day basis. Over the years, the organization grew into more than that, whereas we're not just a voice on behalf of our members, but we're physically involved in helping communities, especially the poor communities. Now, we're based in South Africa, um, and so in areas where we live, even where I live personally, it's in what we would call a rural area. People around us are very poor, they are very needy, and our neighboring countries even more so. And we saw a great need to reach out to them using the talents of our doctors. Our doctors have the talent of medicine, they can help people with healthcare. And many of our members, not all of them, people joined for different reasons, but are willing to go the extra mile and donate, volunteer their time and their expertise as doctors to help people in rural communities. So, Doctors for Life is all about enhancing the quality of life of people around us, but then also to uphold strong values in the medical profession, as I've mentioned, for instance, sound science in the medical profession. I think sound science in the medical profession is on the attack. Um, there is uh, there is a lot of information being shared on the internet that is not always sound science, and where science isn't scrutinized enough. And I think maybe people became aware of it during COVID, but it's not just COVID; it's many issues. And so we're passionate uh, about keeping that integrity of being sound in mind and when we approach these issues. As I've mentioned, a deep desire that we, however, had all the years is to do more than that and to apply what we've learned, and apply the talents of these doctors in reaching out to people as well. And those are the people that are very often affected um, uh, with various issues, whether social, political, or things that just beyond their control. And it's an opportunity for us to show what doctors are actually there for. Traditionally, over the years and centuries, doctors have always been the caretakers of society. I think in the last century, or not last century, maybe the last few decades, there's been a lot of pressure on doctors to not uphold that value anymore. And in fact, in some countries, I think there is pressure for people, or the tendency of people to start seeing doctors in a different light. And a lot of that is also politics and policies that governments adopt. And we feel that should not be the case. Doctors have had that traditionally good, can I say, uh, uh, not a symbol, but they projected that they are caretakers of society. They should be the ones who lead the way in showing what care is all about with patients. And I can just use an example, and I'm jumping maybe a little bit ahead now, but we have a clinic in Mozambique, and people come to us and say what makes our clinic different from the government clinics and the other clinics in the area. Of course, our services are free. We don't charge any money for any of the services that we provide. But what really touches the people is not that. And we don't always have all the medicines. What makes them come back to us is the fact that they get care and love and compassion in the caring as a doctor-patient relationship. Otherwise, they're not just another number. When they arrive at our clinic, people give attention to their individual needs and them as a person, and that's something that you very often lack in, and not just in the poor countryside, they say, even in countries where there are very smart hospitals, but very often there's that disconnect between, you get to a hospital, you expect some level of passionate care because patient is sick, and they seek that, and that is a wonderful opportunity to then offer that. And I think that's a large part of many people's healing as well, is when they receive just that, not just the right medication, but an actual doctor. And everybody would speak about that, whether you're wealthy or poor, is if you go to a place and you were in extreme need and you walk out there and you can tell people, well, I didn't get all the medicines that I needed, but that doctor really took care of my needs. He really went all the way. And that's really a passion that we have, that we want to apply to our daily lives, in providing healthcare to poor communities. And of course, on top of that, a good medical product as well. It's not just about compassion. Some people might think, organizations that help patients in these poor and rural communities give them a lesser value, lesser medical service of lesser value. But that's not true. We do our utmost to still keep the highest standard in medicine, while providing them what we can in those certain situations, or in that country where they might not have all the resources or all the equipment that you would have in a first world country.
That's something important to highlight, because I do think some people still think that way, right? They see it as, oh, it's just humanitarian, they're gonna do what they can, but it's not about that, right? It's about providing good care, really actual factual good care. And I like when you say, because care is so much more than just giving medicine, right? It's about really talking to people and welcoming them and making them really feel seen somehow. And
listening to them.
Yeah,
it's actually more about listening as well. Talking, there's a point for talking, but very often it's listening. And a person that is in a desperate need, with a really serious health condition, needs that. It's a fragile, for many people, it's a fragile time in their life. And that's why it's such a wonderful opportunity to then make a difference in that person's life, and not just provide medicine, which they need. And of course, that's what we do. That's our profession. But also to offer them more than that, maybe give them some hope, and care in the way that we sometimes have patients, and we go the extra mile. You go and visit them at their home. You get into a car and you ride through the bush, and you need 4-wheel drive, and you go and visit them there, and go a little bit beyond the normal, just the patient-doctor relationship in the hospital, in the clinic. And I'm thinking now specifically of our clinic in Mozambique. We have another one as well, which we just started recently in Malawi. It's also in a very remote area, and that's still a small one. And both have their own different challenges. It's, I think for sometimes the idea of working in Africa and this in the bush and so on has for lack of a better word, a bit of a romantic outlook of, that would be nice to do that for a while, but that's exactly it. For many, it's just for a while. They want to go just for a week or two and then come out. But some of our volunteers stay there for years, and they have to endure quite a bit. They stay in the communities with the people, and as I said, resources and things are sometimes lacking, but they do the best they can, and that alone says quite a lot to many of the people already. We once did a outreach in South Sudan, in the regions of South Sudan, and people afterwards, on a following up visit, and we did eye surgery there, came to us, and they basically said that the faith that these people have that came to this area, and as I've mentioned, we are Christian based. They said, well, that must be authentic, because who would want to travel all the way to South Sudan into this area? Now, to get to that specific area is extremely difficult and very costly, but it's also very remote, and they just don't have other help. And they said, well, what really touched the patients were the fact that people would actually do that and come all the way to them and offer them assistance, whereas many others would, that would not be their first choice. And so it's a privilege for us to be able to do this work and to make a difference in people's lives and offer them that hope, and give them something that's of value to them. And when we leave there, that they can, that they have something solid that stays with them.
That's amazing. Johan, these clinics that you're mentioning, they are part of the Aid to African program, right? Could you give us an overview about this program and how does it work and fits into the whole mission of Doctors for Life?
So the medical aid program, it started so I said, the organization started in 1991. A number of years passed before we got to the stage of starting a medical outreach program, which we called Aid to Africa. So that's in short for medical aid to Africa. And although the word Africa is in the name, we would be quite happy to expand that even to, we've had invitations to Brazil, to India, and to start similar programs there, specifically eye surgery as well, where river blindness is apparently quite a problem, but cataract surgery as well. It's all over the world a problem. And it coincides with what we stand for, because, as I said, we want to offer what doctors have, the talent of being able to offer healthcare to communities that really need it. And our desire from the beginning has been to reach the really remote areas. So in Africa, there are many areas that are very poor, but there are areas that basically have nothing. And those would be the areas that we want to focus on. It's not just needy areas, but really areas that the people basically have nothing. And we've been some of the poorest places on the planet, I believe, because of that vision. And those places exist even in our neighboring countries, in Zambia, in Angola, Malawi. We do outreach work even in Botswana, although Botswana would not be seen as the poorest of those countries. Mozambique was at one stage the fourth lowest when it comes to healthcare. It's changed now, and also we also look at statistics like mortality rate with children being born. Some of the places that we visit are so remote that the patients, maybe it's a once in a lifetime experience to go to a medical doctor, a qualified medical doctor. Many of the areas have clinics in some of the neighboring countries. They have small clinics, but they are run by clinicians. They're not doctors. They are either nurses or what they call health clinicians. And so we really aim to reach those areas and take healthcare to them. Some countries have the policy where, no, do it in the cities, to come, bring your doctors, set up a clinic or do surgery in the cities. We'll bring the patients to you. But in reality, that doesn't happen. The poorest of the poor get left behind in the rural areas. And those are the ones we really want to reach. And so that's how the program developed. Many of the areas that we've visited over the years, our doctors have to stay in tents. We travel through the bush. We live amongst the communities during that time. And we pitch tents and make our own food while staying with them for a week or two, and then move on. We try and fly in the doctors, but many of them are specialists, so they don't have time to drive, because sometimes it takes 6 days just to drive to the specific area. And that's how the work grew. But we realized at one stage that doing outreach work like this is actually a compromise of having permanence in a country, or permanence in an area. And that's where it started developing that we should start permanent clinics. Now, of course, it's a lot more expensive, and you need volunteers and staff who's willing to actually go and live there permanently. or on a rotation basis. And so it's a lot more challenging, but I would say that is still the end goal. And that's why today we have 2 clinics. We just had a meeting today about possibility of starting something in Uganda. I know in the DRC, there's a very remote area that's been pleading with us for years to start a clinic there. And it's just, the need is just incredible over. So, a big need, however, is to find partners and people who support us to actually help us, to hold hands, and that we can do the work together.
Yeah, this was the point that I was thinking just now, because to be able to reach such far areas, with all the challenges that you mentioned, you must rely on good collaborations, right? I mean, it's volunteering and it's donating, but also it must be about, at least with the communities. How does that work, really?
So we are dependent on our partners and volunteers. So there are 2 sides of it, and we always tell people sometimes it's easier. Both are very challenging to find volunteers who are committed in doing this work in the way that I've explained. Especially, many of our volunteers do it without salary. They find their own donors. They find their own support groups, whether it's churches or companies or individuals, families sometimes, who support them while out in the field. And it really depends on how much funding we have as well. And then, of course, the other part is the partners who support us to actually run these clinics and offer these programs in the rural areas. And we are very thankful that we've had various different supporters over the years. But as our work is growing now, we obviously see an enormous need to get more support and more partners. And the more we get, the more we can do. We can't, at this stage, we definitely need partners for DRC and for Uganda. And even in the work that we do in Mozambique, medicine is getting really expensive. Fuel costs go up, and running costs. So these are huge needs that we have, and we absolutely dependent on our donors and partners and volunteers, medical staff, but also other staff, not just medical staff. We also use staff, the supporting staff for the medical staff. You need cooks, you need drivers, you need people who can fix cars and so on. So
it's not just the end, right? The end of the line.
Yeah,
you need support.
That's right.
Yeah,
that's right.
Johan, considering that, and maybe some of our listeners got interested and want to get involved, what are the best ways to help you guys keep going?
The best ways would be to support us via our website, maybe financially. We use a system. It's a UK-based donation system called Give and Gain, and people can support us financially in that way. Other ways is with actual donations. Medical equipment is a huge thing, and we know there are people that have access to these, especially hospitals, who sometimes have a turnover of equipment. There's nothing wrong with the old things, but they get the latest technology, and we would be very happy to be assisted in that. I think of 2 great needs we have already for our clinics. One is an ultrasound. We have a maternity ward in one of our clinic in Mozambique where we help ladies deliver babies, and the ultrasound is critical to know whether there's a breach or complication. And ours just packed up now, so we urgently need a new one. We also urgently need an X-ray machine. We had a really good one, but it wasn't, unfortunately, the head also packed up. And so that, of course, helps for fractures and other abdominal procedures and so on that we need to know with the X-ray machine, do proper examinations. And the interesting thing is, in the area of Mozambique where that clinic is, there is hospitals. It's like an hour or 2 hours drive from us, but they don't even have sometimes proper equipment. And to get a patient from us to there, the time is just, it will just take too long. Sometimes there are emergencies, especially with deliveries. You need to act quickly. So at the moment, we are also looking at, for instance, purchasing an ambulance. We got some donations. We would need a bit more to get a decent vehicle, just to use an ambulance to transfer patients. We don't do surgery at our clinics. We have to transfer them to government hospitals, and that obviously also needs to happen quickly. So those are examples of things that we need urgent help for. Something else I didn't mention previously, but we also do orphan care. We've got about 150 orphans that we take care of, and they obviously need food on the table, and which is what we provide at daycare centers. We have ladies that cook for them. We send the food to them. And yeah, so those are different needs and different ways that people can get involved, or volunteering, or just by sending us food parcels. Some people feel more comfortable, and instead of donating financially, by donating in goods, like I mentioned, medical goods, or even a vehicle, a secondhand vehicle or something. And we would be very, very happy and thankful for anything like that.
Thank you so much for joining us today, Johan. I really like talking to you.
Thank you very much.
And for everybody listening, if you enjoyed this episode, remember to press subscribe on YouTube or in your podcast app, because that shows the algorithms that this is an important conversation and more people can learn about the importance of the Doctors for Life in South Africa. Bye, and I'll see you in the next episode.